Welcome everyone, and thanks for being here in this second seminar of this Lunedì della Storia Culturale, this cultural seminars of cultural history organized by the Centro Interuniversitario di Storia Culturale in collaboration with the universities of Pisa and Venice. Today we are very honored and pleased to have with us Bettina Hitzer, who is going to present a paper on cancer and the emotions in 20th century Germany. Bettina Hitzer is a Heidelberg researcher at the Hannah-Arendt-Institut for Totalitarianism Studies in Dresden. After her formation at the Freie Universität Berlin and Universität Sorbonne, she has worked at the University of Bielefeld and the Max Planck Institute for Human Development in Berlin, when she was a Minerva research group leader at the Center for the History of Emotions. Her research interest focused on the social, cultural, and political history of the 19th and 20th century, and in particular on the history of migration and emotions. Her current research project deals with the history of the adoption of children. Today, she will present a paper on emotions and illness, and in particular on the development of emotional regimes related to cancer in 20th century Germany. This work was published as a monograph last year by Colette Cotta and was awarded the Leipzig Book Fair Prize in the category of nonfiction. The title is Krebs Füllen and is going to be published next year by Oxford University Press. So after the presentation of the paper, we will have the Q&A section. So you can just book a question, just writing it in the chat. As we have seen, the seminar is also recorded and will be available on YouTube and Facebook. So Bettina, the floor is yours. And I remember the title of the presentation, which is Cancer and the Emotions in 20th Century Germany. Thank you.
Yeah, many thanks, Elena, for this kind introduction. And thanks to both of you, Ignazio and Elena, for having invited me to present my work here. I'm very honored to do that here. Okay. Yeah. I will present my book, my research, the research for my book this evening, and I will follow a little bit the structure of the book in four chapters. This is Valentin Guderdarel. She was making a living as a professional dancer in turn of the century Paris when she met the well-known painter Ferdinand Hodler in 1908. At the time, she was 35 years old. Hodler was immediately enchanted by her and she by him. They eventually became a couple, even though Hodler remained married to his second wife, Berthe. For a few years, Valentin Guderdarel stood model for Hodler, for instance, as graceful dancer for his wall painting Blick in die Ewigkeit, Glimpse of Eternity, or for this picture, Tête de Femme Française. In 1913, their daughter Pauline, called Paulette, was born. Shortly afterwards, Valentin Guderdarel was diagnosed with abdominal cancer. She died on January 25, 1915. In the roughly 2 years that remained them, Hodler painted his beloved again and again, as if he wanted to capture her in life, while also documenting every detail of her dying, a unique oeuvre of human mortality. And I show you one of the first pictures from her cancer story, and these are the two last. Why do I show you these pictures? First, they have profoundly moved me when starting this research project. But to me, they are more than that. I look at them and I see a major question to the history of emotions. For these paintings reveal an infinite amount about the dying of Valentin Guderdarel, and at the same time, very little. We look at her from the outside. We get to know the view of an observer. But what do we learn about her thoughts and her feelings? This is precisely what cancer history is confronted with for most of the 20th century. There are a myriad of sources providing information about the most diverse aspects of cancer, but almost always it is a view from the outside, the gaze of a doctor, of nurses, of health politicians, of cancer researchers, of journalists, or of society. But only rarely did cancer patients themselves speak or write, at least for Germany until the 1970s, when cancer patients first raised their voices in greater numbers and started to speak publicly about their illness. Could pictures like Hodler provide access to the feelings of cancer patients or the relatives and friends, because we could read them as testimony to their feelings, in this case to the importance Valentin had for Hodler, to his almost obsessive preoccupation with her dying. But then aren't we reading his feelings into these paintings because we think we know what we would feel if we had painted them? Are feelings something that does not change in its substance, so that we can use our own feelings today as a kind of seismograph to read and understand the feelings of past times? I would not be here today if I subscribed to this bluntly. So what are feelings? One could give a long lecture on this alone, since there's an ongoing debate about what feelings are and how they function. But there's one question that psychologists, neuroscientists, and social scientists have argued over and over again in recent years, and that is the question of how universal feelings are. Some neuroscientists, such as the American Paul Ekman, are convinced that feelings are always the same everywhere. The only thing that changes would be the way feelings are expressed. But even this change is relatively superficial from Ekman's point of view, because for a few milliseconds before the cultural shaped expression of feelings takes over, the unaltered evolutionary expression of the feeling shows itself. And that is what he's arguing for in a number of books, among them this one, Emotions Revealed, Recognizing Faces and Feelings to Improve Communication and Emotional Life, a book published in 2003. However, this position has been challenged in recent years by a number of neuroscientists who have come to the conclusion that emotions themselves are shaped by culture, not only the expression of emotions. And by culture, that means also they are shaped by history. These scientists include, for example, Lisa Feldman-Barrett, director of the Affective Science Laboratory at Northeastern University. And this is one of her major book on this, How Emotions Are Made, The Secret Life of the Brain. I don't want to go into much detail here because that is not the central topic of my talk today. But for everything what follows, it is crucial to know how I define my take on feelings. So that it is feelings from a history of, or from my history of emotions perspective. I agree with Ekman that and others insofar as I assume that something about feelings is universal. However, this something is not the feeling itself, but the universal ability to feel, to experience feelings as a phenomenon in which the body is involved, but also the thoughts, the cognition. A situation doesn't cause fear per se, for instance. It is because I perceive it in a certain way that I am afraid. The fear I feel is strongly influenced by what I learned about fear in childhood and later in life, how I evaluate the feeling of fear, how I describe fear to myself and to others. And In this respect, feelings are individual because they are resulting from the individual life story. But there are also societal components of the feeling of fear and other emotions, because you can find emotional regimes, emotional norms in society that fundamentally shaped the feeling of emotions like fear. That is why fear, like all other feelings, is not the same everywhere and at all times. That's why feelings, in my view, have a history. Today, I will talk about a specific history of feelings, a history that was important and defining throughout the 20th century in Germany, the history of cancer and the emotions. This story is partly concerned with individual experiences and feelings, but these individual experiences take place within a framework that is shaped by society, by therapeutic possibilities and conditions, by scientific ideas about emotion and cancer. And so one could translate this into the image of a landscape on which each of us moves while creating their own life stories. I've chosen this image to illustrate this idea. It's an image taken from Conrad Weddington's book, Organizers and Genes, a book on genetics, and also the first book advocating the idea of epigenetics. And the individual is the ball, the tiny ball you can see, and the landscape of experience that is all the other things. You can see that it's the tiny ball cannot roll everywhere, but there are paths, roads that the ball can take. And but there are different choices, different possibilities pre-shaped by the landscape. During my research, I thus explored the map of this landscape, its morphological structure, as well as its paths and roads. I tried to grasp how this landscape, the social conditions in a broad sense, have influenced the feelings of those moving through it. In this case, of those affected by cancer, as sufferers and survivors, as relatives and friends, as medical staff, as researchers, and finally as those who perceive their bodies and are afraid that they might have cancer. This landscape of experience, to stick to the metaphor, has been reshaped again and again throughout the 20th century. 4 fundamental factors were at work, which I have therefore explored in 4 different chapters of my book. My first investigation led me into the spaces of medical and psychological research. What significance was attached to feelings here? Were they even considered as causes or factors promoting healing? How and why did researchers come up with the idea that emotions could perhaps cause cancer? And how did they investigate it? And most importantly, how did these research findings affect the way cancer patients were treated and how they felt about themselves? My second approach led me to the question of when cancer was invented as a curable disease that could be healed at an early stage. For it was only when the possibility of a cure was seen that it could be considered reasonable to detect cancer early. This moment finally occurred in Germany at the end of the 19th century. At that time, the first early detection campaigns were conceived in Germany. They were to permanently alter the view of the bodies of what constitutes health. How this change occurred is one leading question of my second chapter, as well as how emotions were used to teach us this different view of ourselves. And finally, how did this affect our feelings towards cancer and towards people suffering from cancer? For example, with regards to blaming cancer patients for having fallen ill with cancer. My third approach to the history of cancer and the emotions has taken me further into the lives of the people who suffer from this disease. How people feel about their illness has a lot to do with what they think they are suffering from. With regard to cancer, this insight is by no means trivial, for cancer diagnoses were withheld from people for most part of the 20th century in Germany. Did cancer patients suspect that they had cancer? What did this concealment mean for their relatives, for doctors and nurses? And what assumptions about feelings led doctors and nurses, priests and psychologists to believe that concealment was a better, the more bearable solution? Hope and despair, I learned while working on this chapter, fundamentally changed their character over the course of the 20th century. And finally, my last chapter. Cancer therapies have significantly changed over the last 100 years. This development alone has altered what people feel when they are diagnosed with cancer or have to receive cancer treatment. However, it is not only about the chances of recovery. Feelings associated with cancer treatment changed also because the varying therapies had different side effects, because the impairments I had to live with were different, because therapies involved different forms of encounter and movement, different sounds and smells. This is the focus of my fourth chapter. So let's start in New York, more precisely on an island in Manhattan, now called Roosevelt Island. Until the 1920s, this island was a dreaded place. A prison, a psychiatric clinic, a quarantine hospital for smallpox patients, and a workhouse were located here. Then everything was supposed to change. The island was renamed Welfare Island, and the city of New York built a number of new hospitals here, and that is what you see on the postcard from 1945. One of the most famous hospitals was Goldwater Memorial Hospital, built in 1939. Not far from it was the New York City Cancer Institute, which had about 200 beds and was specialized in the care of terminally ill cancer patients. It was here that psychiatrist and neurologist Milton Tarlow and psychologist Irving Smallheiser conducted a study sometime around 1950-1951, which they published in the prestigious journal Psychosomatic Medicine. This was one of the very first studies to explore whether personality traits played a role in the onset of cancer. In the United States, psychosomatic medicine was on the rise at that time. Many diseases were then tested for potential psychosomatic interactions. It was assumed that specific psychological conflicts would lead to specific diseases. The so-called specificity principle that had been formulated by Franz Alexander, an Austrian immigrant to the United States. And he also named 7 diseases he considered as classic psychosomatic illnesses, a catalog that has been called later the Holy Seven, and you see the 7 illnesses that were meant. With this specificity principle in mind, Milton Tarlow and Irving Smallheiser set out to conduct this study, the aforementioned study, at the New York City Cancer Institute. They selected 22 patients, 11 women with breast cancer and 11 women with cervical cancer. As was a standard of psychological research at the time, they combined different test procedures to achieve greater validity. First, the women were asked to answer questions about their personal biography during a 1 to 2 hour interview. Then they were confronted with a so-called Rorschach test. And finally, they were asked to draw 3 different human figures, a man, a woman, and themselves, the so-called draw a person test. The Rorschach test was the most important test instrument for them, in their view. They thus made use of a test which was then an established psychological test procedure and was used by both clinical and other psychologists for a very wide range of diagnostic questions, also including military questions when choosing pilots, for instance. During this test, the subjects were presented with a series of inkblot pictures. And I think you know this kind of inkblot pictures because they are now a kind of cultural heritage. You can find them in films and also in pictures and paintings, for instance, from Andy Warhol. The test persons were asked to indicate what the pictures portrayed. Crucial to the evaluation were aspects that most subjects might not have considered important, such as whether the interpretation of the pictures was generally based on their shape, or more heavily considered the color or possible movement of what was depicted. Following this evaluation, the Rorschach test promised to shed light on whether test groups, such as the breast or cervical cancer patients in this case, had common personality traits and whether these differed significantly from the personality traits of a standard or normal group. Although the interpretation of the data revealed differences in the personality profiles of breast cancer and cervical cancer patients, Thalau and Smallheiser believed they could identify some basic similarities. The most important, in their view, would be that all women rejected the female role because they had had a dominant mother who was not emotionally committed to them. For this reason, they, the women, would have developed a negative attitude toward their own sexuality. However, while the breast cancer patients had adapted superficially and lived in a stable marriage that from outward appeared to be happy, the sexual dysfunction was more apparent in the cervical cancer patient group. As evidence, Thalau and Smallheiser pointed out that these women had entered into premarital relationships, married very early, and lived in disharmony with their spouses. Thalau and Smallheiser thus proved the link between a deficient female sexual identity and the development of cancer. However, by outlining two female cancer personalities that were almost diametrically opposed, and yet in their view the same since causing cancer, they revealed how much conceptions of the female role had been set in motion by wartime and post-war experiences. For neither the sexually more active woman in premarital or extramarital relations, nor the woman who superficially complied with role expectations were healthy. Both had developed cancer. From Thalau's and Smallheiser's point of view, what was decisive was what was hidden behind the outer facade. Those feelings that were not acted out, that were suppressed or insufficiently developed. Many questions crop up here. How did it come about that these two scientists put forward such theories at precisely this point in time, and that they initially received a great deal of approval in the 1950s, while only a few years later in the 1960s, the methodological flaws of the study were clearly criticized? And how did the image of a cancer personality that both of them helped to create became an influential idea also and above all in West Germany that was discussed outside scientific circles? I further explored these questions in my book, and we can discuss about this later in the Q&A. But for the moment, we are to leave the New York of the 1950s now and travel on to East Berlin, where at about the same time a film was being produced that was to bear the title Rechtzeitig, eine Mahnung des Lebens, in English, In Time, Admonition of Life. And I hope I can show you now the intro. Yeah, I think it works. I hope so. The film kicks off with these images. The narrator comments from off-screen in German, and I translate for you. Happy children, to them belongs all our love, all our care. Their health must be protected. I doubt any of you would have guessed that these images introduce a film intended to promote breast cancer screening. What does the health of the children, the happiness, the weighing, measuring, and vaccinating of the cute children shown here have to do with cancer? You will already have guessed that there's a strategy of persuasion hidden behind. And this has a lot to do with feelings. When this film was shot in 1956 in the GDR, more than 80% of people suffering from cancer eventually died of their disease. Surgical techniques had not changed significantly since the 1920s in the case of most cancers, the exception being surgery for lung cancer. Nor had radiation techniques progressed much, at least in clinical practice. The first large-scale irradiation device was not to be installed in East Berlin until a year after the film was produced. Chemotherapy was still in the pilot stage and was not yet used widely in East and West Germany. In this situation, the hopes of many physicians were directed toward increasing cure rates through higher use of early detection programs. But whether more early detection could really increase chances of recovery was a bet on the future, was not yet proven. And what people saw whose friends or relatives had cancer was not reassuring in most cases. Even many of those who had had their breasts checked died of cancer. Nevertheless, the early detection campaigns held steadfastly to their mantra, which had already been coined since the turn of the century: detected early, curable. To this end, the early detection campaigns of the 1920s and 1930s had relied on the dichotomy of fear and hope, displaying drastic images of far advanced tumors. And I will now show you briefly such an image from a 1930 film, Fight Cancer, which showed a lot of images like this one. The film Rechtzeitig eine Mahnung des Lebens instead showed this introduction sequence in which children were presented lovingly cared for by medical staff. And you can find no images like the one from 1930 in this film. The purpose was obvious. Early detection was to get a different emotional connotation. It was about keeping fear out of the game. Early detection should be as natural and unemotional for women as it was for them to have their children weighed and measured. That was the first message of the film. The second was that cancer screening was placed in a similar line with other prophylactic efforts in the socialist GDR. In fact, however, these were two different things. Vaccination was about preventing the onset of a disease, while screening or early detection was about the detection of disease. With vaccination, treatment was over. With early detection, it would sometimes only begin. This major difference was to be made forgotten, suggesting a control over fate that did not exist. This was consistent with a health policy that deliberately sought to eliminate negative feelings. Thus, for instance, the Wegweiser Gesundheit, the health guide, produced for GDR television, formulated a few years later, I quote, "In our society, there's no place for fear, pessimism, dissatisfaction, since aspirations and reality coincide," unquote. In fact, however, the 1956 film did play with fear, albeit covertly, for the admonition of life displayed children as embodiment of life. In so doing, the film tied in with older visual traditions of early detection campaigns without explicitly foregrounding this reference. In the late Weimar Republic, the methods were less subtle. In 1931, for example, an exhibition organized by the Dresden Hygiene Museum showed this poster. The commentary noted, "The parentless children are now being pushed around by strangers. The mother died of cervical cancer at the age of 44. The covered subtext to this title was, "If this mother had been more responsible and had gone to the doctor in time, she would still be alive and would not have robbed her children of life's joy and opportunities through her death, which was at least partially self-inflicted." The 1956 film avoided such a direct blame, but conveyed it in a more subtle manner. And as the final sequence of the 1956 film shows, this question of responsibility was amplified by the GDR film in a very ambivalent way. For the film depicted how two female workers, inspired by the example of a fellow worker, went to the doctor jointly, a walk that was much easier for them because they were not alone. And eventually, happy because nothing had been found, they lined up in a crowd of women who, in solidarity, moved past the viewer into a future that was not shown, but was obviously brighter. Responsibility for the children, responsibility for the socialist society, that was the admonition of life conveyed by the film, but at the same time presented here as a kind of emotional resource. Certainly, this is an educational film, but what effect did such a film have? Most importantly, how has such a recalibration of early detection changed the way people suffering from cancer were viewed? How did people who had cancer perceive and feel their own responsibility as a result of these campaigns? These are also questions I want to leave open for the moment, and we can discuss about this later, or you can read something more about it in my book. With this, I will conclude my excursion into the year 1956 for the time being and travel back in time a few years. We are now in Heidelberg in the spring of 1944. 60-year-old Colonel Anton K. has been suffering from stomach problems for some time. He's concerned that he has lost weight. Eventually, he has himself checked out by a radiologist. The radiologist refers him to Heidelberg for further examination. In April 1944, Anton K. presented himself at the extremely well-respected Heidelberg University Surgical Clinic, which you can see here on the photograph, which had been opened barely 4 years earlier in 1939 and was equipped with state-of-the-art technology. Anton K. was examined by the head physician himself, Karl Heinrich Bauer, at the time one of the most famous German surgeons, alongside Ferdinand Sauerbruch, specializing in cancer research and surgery. Before Bauer welcomed Anton K., he had not only read the radiologist's medical report, but also a personal letter that the radiologist had sent him. The letter's intention was to describe the character of the man who Bauer would most likely diagnose with gastritis. And so the author of the letter makes a point of stating that he knew Anton K. as, I quote, a very positive and cheerful person and a devoted father of 4 daughters, unquote. And then the radiologist cautions Bauer that Anton K. thought that he was probably suffering from a benign stomach ulcer, which Bauer almost certainly could operate on successfully. However, the radiologist had voiced his suspicion of cancer to the wife of Anton K. because, and I quote from the letter again, "I know the wife as a very brave woman. She absolutely wanted to have clarity and will try the utmost to spare her husband," unquote. Bauer complied with the radiologist's request and revealed nothing to the patient. On April 17, 1944, the surgery was performed in Heidelberg, and this is also marked in the patient file of Anton K. Bauer immediately realizes that the tumor has already spread too far. Any surgical intervention is pointless. He made a trial incision and closed the abdominal wound again. When Anton K. emerged from the narcosis, he was told that the procedure went well and that he could expect the wound to heal quickly. However, he would still suffer from discomfort for a while and would have to take medication since the actual cause had been a high-grade gastritis that would only subside slowly. After his patient's discharge, Bauer reported to his radiology colleagues, and he wrote, I quote, "Thanks to the particularly insightful attitude of his wife, he, Anton K., took the rapid recovery from the immediate post-operative reaction as a favorable sign, so that he could be transferred to R, his place of residence, in the Reichsbahn ambulance, completely unaware of his true condition," unquote. Most of the patient files I have consulted conclude with such a report, usually less personal, to the doctor treating the patient in his or her hometown. In some cases, however, the contact does not cease even after the patient has been discharged. This was also the case with the file of Anton K. Here I found another document, a letter from his wife from the summer of 1944. There she wrote, "Now, however, the physical condition. I have the impression that the worst stage is gradually approaching. For several days now, the patient has been suffering from nausea almost every time he eats, as well as other great discomforts. I now give only almost liquid food and 2 to 3 pantopone injections, that is a pain-killing opium preparation. However, I believe that I must now switch to morphine. The body is very hard and the circulatory disturbances are evident. The feet swell up to the ankles and the color of the face is already very yellow. Even the eyeballs have discolored. Otherwise, my husband is still very interested in all matters, walks in the garden every day and firmly believes in his recovery. I only hope that until the end, I can maintain the delusion in my patient that he is getting a little better every day, often bitterly difficult," unquote. This letter is the last document about the dying of Anton K. that could be retrieved from his Heidelberg medical records. A message about his death, which was otherwise sometimes sent by the family doctors to the Heidelberg clinic, is missing. Based on his wife's descriptions, however, it can be assumed that her husband died before the year 1944 was over. How does one read such a letter? Today, a notion of emotions is widespread that considers talking about feelings to be therapeutic, whereas the repression of negative feelings such as fear or despair is seen as a form of dangerous self-alienation. From this point of view, the possibility that the K couple did not talk about Anton K.'s cancer, illness, and death appears as a form of loneliness and emotional isolation. But is it legitimate to extrapolate such a conception of the good handling of feelings back to the past? Until the 1950s, a different view of the proper handling of feelings prevailed. According to this view, it was a distinguishing feature of the major respectable person, especially of male persons, to control feelings of fear and despair, to refrain from talking about these feelings and to gain inner strength from this kind of emotional control. In the 1960s, this was started to be criticized fiercely as a bourgeois facade, as repression of the unpleasant. There are documents from this later time, from the late 1960s, 1970s, that recount how people suffered from silence, how they experienced silence as isolation, how silence led to an inner or even quite tangible distancing. But there are no such documents from the 1950s or 1940s. But in this letter, there are clues to a certain distancing. As long as the wife of Anton K. talks about her husband's physical condition, he becomes a medical object, a patient composed of body, foot, ankles, and eyeballs. The wife signals here that she has accepted her role as a nurse, as an extended arm of the doctor, and that she performs it painstakingly. But then the patient in the letter becomes her husband again, a person with intellectual interests and feelings. Should we therefore be wary of a hasty judgment and actually think for once about how much not only the norm, but also the feeling itself, influenced by the norm, could be subject to historical change? In this light, the summer of 1944 would not necessarily have been a time of cruel dissimulation, of lonely despair in the lives of Mr. and Mrs. K. Possibly they both knew or suspected that Mr. K's death was imminent. Nevertheless, they adopted the ban on talking about cancer. Why? Undoubtedly, there was the pressure of outside expectation from the doctors, but also from relatives and family and friends. In addition, however, there could have been something like a kind of silent agreement that they did not want to share feelings of fear and despair because they were convinced that they would be able to control these feelings and thus live out their remaining life together more happily when not talking about cancer and these feelings. This kind of thought experiments somewhat relativizes the claim to universal validity of the current paradigm of informed dying that dominates palliative care. And there are also sociologists in recent studies discussing whether we should, in a way, relativize this paradigm a little bit. For instance, a project conducted at the Ludwig-Maximilians Universität Munich, conducted by Irmhild Sark and Amin Nassim, and they found out that at least some of the dying they talked to, they were observing, didn't want to know, didn't want to die aware of them dying. To the end of my lecture, I would like to return to the place from which I set out at the beginning, New York. However, I don't want to return to the New York City Cancer Institute on Welfare Island. That institute has long since ceased to exist. But just a few hundred yards from that place stands one of the world's leading cancer treatment centers today, the Memorial Sloan Kettering Cancer Center. The history of this institution is closely intertwined with my last topic today, chemotherapy as a new regime of hope. In 1948, Cornelius B. Rhodes was appointed director of the memorial. Rhodes had previously participated in the US military's chemical weapons research program, and that is why he has his uniform here on this photograph. This program focused on researching the effects of sulfur nitrates, the substance that had caused fear and terror in the First World War under the name mustard gas. It was already known at that time that mustard gas affected the blood counts of those who had come into contact with it. Some researchers from the American Chemical Weapons Program were interested in investigating this effect, actually with the objective of looking for agents that could prevent or weaken this effect. They carried out experiments on animals. Research on humans appeared to be ethically problematic, of course. However, there was one group of people who, so was the reasoning, could possibly benefit from the effect of mustard gas or related substances. These were people suffering from leukemia or lymphoma. In fact, the very first experiments showed that lymphomas regressed under the effect of sulfur mustard, but only for a short time. Then the lymphoma returned and the trial subject died. During the war, the results of these experiments were classified. Shortly after the end of the war, however, chemotherapeutic research began on a large scale, and Memorial, under the direction of Rhodes, took a leading role in it. Chemotherapy multiplied the options for cancer treatment in unprecedented ways. Previously, there were only two options: surgery and radiation treatment. If surgery was possible, surgery was usually performed. If recurrences or metastases occurred later, surgery was sometimes still performed, but there was then hardly any hope. Surgery was then rather carried out to maintain hope or for palliative reasons. For example, because a tumor was exerting pressure on a nerve and causing pain. Surgery may also have been combined with radiation. Radiation could be given in several series and thus lasted longer than surgery. But again, the chances were small once recurrences and metastases occurred or if the tumor did not respond to radiation. This all changed with chemotherapy because now a whole range of options became available pretty soon. Different chemotherapeutic agents that could be combined in different ways and administered in alternating doses. If one substance or combination of drugs failed, that was soon no longer the end of medical options. Perhaps another combination still worked. This steady multiplication of therapeutic options has been continuing up to the present day. The so-called compassionate use, the use of not yet approved drugs permitted under certain conditions, is one of the latest consequences of this multiplication. This history of chemotherapy, which I've only sketched out very briefly here, is not something I would like to elaborate on today. Instead, I would now like to leap almost to the present and end with a passage from a novel set at the Sloan Kettering Institute. In this novel, published in German in 2010, in English 2007, author Rafael Iglesias tells the story of the happy marriage between Margaret and Enrique that began in the 1970s. In between the scenes of their first meeting is Margaret's dying. For 3 years, Margaret had agreed to all sorts of treatments, fighting to be enrolled in trials of novel drugs. But now she tells her oncologist that she doesn't want to try another drug. Still, her oncologist is eager to persuade her to try one more. Margaret's husband, Enrique, watches him and notes, I quote, "The handsome, dictatorial, and Enrique could now see soft-hearted man argued passionately and against all the evidence. There are new drugs all the time," he said. "I have patients who have lived for years with metastasized cancers worse than yours. The scans show your tumors aren't growing. We can find you a drug trial." Enrique knew that these statements were nonsense. And yet Enrique found himself engaged by the specialist's irrational invocation of what had certainly died for Margaret, namely the belief that further struggle was worthwhile. Enrique kept his pace, but the doctor's words filled him with shame and doubt. In September, Enrique had supported Margaret's search for a miracle cure. Trying desperate measures had also reassured all who knew her, especially her sons, her parents, and her siblings, that everything had been done to save her life. But for Enrique, there had been the cost of time, robbed from her farewell. Margaret answered the pleading doctor in utter despair. Tears flowed and her voice quaked while she curled up into a fetal position. She shrank from his words of optimism, wincing as if they were lashes of a whip. She pleaded, "I can't do this. Please, please let me go." Hope for a new agent is portrayed here as an extraordinarily powerful emotion that pushed everyone, the patient, the husband, the doctor, over 3 years to search for ever new, ever less promising chemotherapeutic protocols. The drug, which at the same time meant torture for Margaret, became a symbol of hope for her as well as for everyone else. It is only when Margaret has reached the ultimate of her capacity to suffer that she is able to decide against this hope. But although she has made her decision and her husband has promised her support, the power of this hope is still so enormous that her husband can hardly resist the promise of hope in the doctor's words. For her, hope becomes an almost physically palpable instrument of torture against which she fights with the utmost of her remaining strength. The price Margaret and her husband had to pay for the tardy renunciation of hope was the lost time they could have spent together, not intending to Margaret's bruised body, but in talking to each other and saying farewell to each other. I do not want to stop here. This is not a plea against hope or against repeatedly attempting a new therapy, and this is not at all my expertise. The therapeutic options available today are more promising than ever before, and the chances of recovery have increased. Conventional chemotherapy is by no means the latest version of the therapeutic toolkit anymore. But hope is not just about numbers and probabilities. Numbers and probabilities can, however, develop their own emotional dynamics, as we've seen here in the passage from Happy Marriage, just as our way of feeling is influenced and shaped by many other feeling factors. But we often regard what we feel unquestioned as the very expression of ourself, without considering the effects, the influence of society, of emotional norms, of history. Getting to know the history of these feelings helps us gaining a certain distance to ourselves and to our feelings. And that is a moment of freedom, I think, that the history of emotions can perhaps provide us with. Thank you for your attention.
So thank you very much, Bettina. That was such a fascinating presentation. I'm looking forward to the English version of the book, actually. I'm so curious after your presentation. So is there anyone who has got a question? You can just write down in the chat and we will allow you, we'll open your microphone. So you can just write it down. Meanwhile, I know that Ignazio has got a couple of questions and I have a couple as well. So Ignazio, you can start anyway.
Thank you. Thank you, Elena. And thank you, Bettina, for this stunning and comprehensive talk, which indeed makes you want to read your whole book. Your intervention touches a very large number of questions and could make us to perceive as your subject, the cancer emotion, have a multidimensional one, which touches social organization, medicalization, and so on. So I have a lot of questions indeed, but I will do my best to concentrate it in 2 or 3. The first question is about this multi-level dimension of your subject. You have started with Ferdinand Hodler, a painter which I like very much. And you have shown us the portrait of his femme, but what is interesting, I think, is that he also painted a landscape, which from the window, from the hospital window of his wife. And why I recall this? Because his landscape recall the picture you have shown us of his femme on her bed, so the line, and so recall us that emotions and cancer emotions circulate also in the artistic work and are very important to interpret it. So I come to my question. The first question is a more general question about what you have in your book have called take some notes. The dovetailing of individual experience as social condition of experience, and it deals with what Richard Sennett once called the intimistic society, the new intimistic society of modernity. So could you spare some words on the relationship between cancer treatment and emotions, as you have analyzed it, and the intimistic social regime, which is our own now. In particular, if you think on about the difference, not the difference, but the interrelationship between the social social emotions and the individual one. Okay. The second question, it's general too, and deals with the tragic sense of life, which we may call the tragic sense of life. Several scholars speak now about the occultation of the tragic sense of life in our own culture, our Western culture. Did you think that this interpretation, this cultural interpretation, fits or doesn't fit with your cancer emotion analysis? And the final question is a political one. When I was listening to you, I wonder if there may be a social analysis of cancer emotions, which may include the political dimension, in particular in shaping emotions communities around the disease and its emotions. And I think to some more general events in our society, such as pollution, so the detecting of cancer disease in the certainly area or cities. In Italy, we have a lot of examples of these problems, such as the city of Taranto in the south of Italy, which are huge industrial steel industry, and the consequence of this on human health. So can we talk about emotions community around cancer and how? Thank you.
These are three very big questions and not so easy to answer.
I apologize.
I think I try to begin with the first question about the intimistic society and Richard Sennett. I think you can see the coming into being of such an intimistic society also in my history of cancer and the emotions around the 1960s, 70s, when you have this shift towards talking about cancer and towards justifying this talking with concepts like authenticity, that you and also with a psychological justification that in order to live authentic relationships, you not only have to have feelings towards the other, but you have to talk about these feelings. You have to know about the other's feelings, and you have even to work on your own feelings together with the other. This concept of emotion work that also comes into being during that time, and that this is not only this is in the beginning. This is kind of also a liberation, as it's felt like a liberation and an empowerment of patients, cancer patients, that who not only want to talk about their cancer diagnosis, but about their feelings, who want not who object to being stigmatized, and so they want to talk about it. But over the years, this also changed into a norm, into the norm of having to talk about your cancer diagnosis, of having to work on your emotions when having cancer. And this is something people nowadays, sociologists, like I mentioned, Amina C. and Umhat are discussing today, that this is kind of dictate now also in a way that it is not possible, or it is possible, of course, but in palliative care and in hospitals, the norm is that one has to talk about the cancer diagnosis, and then that people have to die aware of dying, and that they can choose, of course, but it is very difficult because if they choose against this norm, they will have difficulties. People won't understand perhaps why they are doing this, and they will be people will tell them that they repress their feelings, that they are not authentic, and things like that. So I think there is a kind of intimistic society in this story too. And then your question about, your third question about the political dimension and emotional communities. If I understood you correctly, you wanted to the question is about whether political factors are constituting emotional communities with regard to cancer?
The question is about communities which could appear and aggregate and shape themselves around a social cancer as a social problem derived by pollution, industry, and so on. So if we can detect it and analyze a political emotion linked with cancer disease and its emotions.
I think the first political emotion coming from discussing cancer is also in the 1970s, when people are using cancer as a metaphor for a society that is characterized by repressed emotions, like by a repressed past, and so on, and that they are. We have, for instance, a book by Fritz Zorn, which is called Mars. I think there's also an Italian translation. I'm not sure, but I think Mars, the god of war. That's the title of this book, and it's written by Fritz Zorn. It's a Swiss young man coming from a wealthy family, and he interprets his cancer is coming from the bourgeois family he has lived in, which is only concerned with a facade of bourgeois society and not with the real problems of life and with real life, the real political problems. And this becomes part of a political discussion about the student movement and so on, and also the peace movement that they make fear a political emotion, that they in the 1970s and also in the 1980s, coming from this cancer discussion, argue that you have to have fear and you have to talk about your fear, because fear is the emotion that makes you aware of political problems, and that gives you also the force, the power to fight against these problems, because in talking about these fears, you can transform the fear into rage, into anger, and then you can form groups, you can have demonstrations and go on the streets, and you can act politically. This is a very important movement coming for where cancer and emotions are involved. Yeah, and the last one, the last question, the tragic sense of life. I think this is very big, and I have to think about it a little more and can give you an answer perhaps later.
Okay.
So meanwhile, we have a question from the chat, and then I will ask mine probably. What are the distinctive features of the German case with respect to other European countries and the United States? And my question concerned naming and words. At least in Italy, sometimes the word cancer is avoided, and they use alternatives on the one end. On the other end, cancer is used as a metaphor for many issues and problems. So I was kind of impressed by the comparison you made of the movies in the 50s and in the 30s. So was there a different approach to the naming of the illness through time? And how was it connected also with the perception of emotion, fears? Thank you.
Yeah, thank you for these interesting questions, these important questions. The distinctive features, this is, there are some movements, some shifts and tendencies that are very similar for a lot of European countries and also the US. But for instance, with regard to the psychosomatic discussion about cancer, which I talked about in the first part of my lecture today, you have a very specific, a very particular German discussion, which I didn't mention in my talk, because in the US you have this this discussion about about cancer personality, and there's a very anti-feminist feature in this discussion. And in Germany, in West Germany, this you can find this also, but there's also a part of it dealing with the past, with the Nazi past, in this psychosomatic discussion, because a lot of psychosomatic physicians taking part in this discussion are arguing that that cancer is also a reaction to a repressed guilt. And they make a comparison between cancer patients and Nazi people that had become guilty and that had repressed their guilt. And so there's an individual discussion about individual patients, about psychosomatic on an individual level, but there's also a political dimension to it, and that is also linked to your question about metaphors, that there's a cancer of society in the early 1950s in West German society because of that repressed guilt. And so there's this pathology of the society seen as cancer, and that this is linked to this repression. And this is later on when the Mitscherlich couple, Alexander and Margarete Mitscherlich, are writing their book on the German inability to mourn, die Unfähigkeit zu trauern. They also come back to these kinds of psychosomatic consideration, not about cancer, but they are tying in this discussion. And there are many other differences I could name to other countries. For instance, the moralizing of the early detection campaigns in the 1920s and 30s. I've shown you these posters from the German Hygiene Museum about the parentless children. These are posters you wouldn't find in the United States, for instance. These are different kind of moralizing, and also the moralizing that is not only tied to the parents but also to the Volk, that you have the duty towards the Volk to stay healthy, and thus to go to early detection programs and to detect your cancer early. Naming and avoiding, these are also very important questions. In the around 1900, there's a big discussion among physicians about how to talk about cancer and how to name cancer when talking about it. And they overall avoid the name cancer or carcinoma or things like that. And they are talking about Geschwulst. That would be in English something like tumor, but benign tumor, more like that. Ambivalent terms, or about ulcers and so on. So they are not only avoid the term cancer, but they also avoid the idea that this is something that could end with death, that couldn't be healed. You can, this is an overall consensus among physicians in the 1910s and 1920s. But at the end of the 1920s, there are more and more discussions about whether one should be more explicit about the diagnosis and also about the term. And there are some lawsuits and some Urteil. I'm looking for the word. Some the law courts they say that one have to be more open about the cancer diagnosis, that people have a right to know about their diagnosis. And what is interesting is not only about this autonomy and informed the information of the patients, but it's also about the feelings. The law courts, they also discuss the feelings attached to a cancer diagnosis. And in the 1930s, there are some who argue that the feelings are not that devastating, that you won't be desperate when you get a cancer diagnosis, that you have not to be desperate, that you have to be brave and courageous, and that therefore physicians have to name and have to use the word cancer. And this again switches in the 1950s when there's a renewed consensus on not talking about cancer and not using the word cancer anymore. And yeah, that has changed today again. Cancer as a metaphor, I talked a little bit about that. Cancer is used as a metaphor from the beginning, from the 19th century onwards. It's not such a widely used metaphor as, for instance, the bacterium, but it is used, and it is used against to name Jews, to name socialists, to name political opponents, even before the Nazis came to power. And it is a very powerful metaphor then for all these political opponents, for racist stigmas, for stigmatizing for racist reasons. But after 1945, there are a lot of discussions about using cancer as a metaphor, and it's much less used after that, after 1945.
May I just, last question. So it's very interesting what you have said about the metaphor of a cancer, and this reminded me to a main discourse about cancer at the beginning of the century. I mean the discourse of degeneration. So I think that in social discourse and in political discourse, cancer as a degeneration of society, of human beings, and so on, was the center of the discourse, of the social discourse. But in this perspective, I wonder if we in order to avoiding disease, traditionally, the religious discourse was a big deal, no? Mm-hmm. And in 20th century, it's about cancer. What church discourse? What they say? What they do about the possibility to manage emotions, manage disease emotions. Have mm-hmm. you treat this point, or?
Mm-hmm. Yeah, there's a debate, a fierce debate between physicians and priests and pastors from the Protestant Church and from the Catholic Church, whether how to deal with cancer patients and how to talk with them, also about this issue of telling them, because the priests and pastors usually argue they want to tell patients in order to have them prepared to die as a Christ, with all these rituals and so on. And the physicians, they don't, at the end of the 19th century, they don't want priests and pastors to tell the patients, and they don't want to have them on the cancer stations, on the cancer wards, because they say every time a priest or a pastor come to our station, it's like death is coming, and we don't want patients to be upset by the presence of pastors and priests. And this is more or less the position in the first half of the 20th century, and then at the beginning in the 1950s. There a new debate among physicians, but also among psychologists, and now also theologians starts. And this is a debate about what is hope, and whether the hope from the church is something different to the hope that physicians can provide, because before hope from the point of view of the physicians was the hope of a recovery or feeling of cure, and from the point of view of the churches, it was the hope for life beyond, the transcendental hope. Then they, during this debate in the 1950s about the significance of hope, there's a kind of not consensus, but they're coming together, because even the physicians they say, so we can have different hopes, and perhaps it's not that when the hope of a cure, of living, of surviving the illness is destroyed, that the result is always desperate emotions and so on, that we can perhaps have hope after this hope has been destroyed, and not transcendental hope, but a kind of hope for a further good moment in life, for dying without pain, for filling the remainder of life with something intense, with something good. And at the moment when this kind of new hope regime, also little hopes after the hope of recovery has been lost, became accepted by physicians, then the big cleavage between physicians and theologians ended, and they came together in a way, and they told patients about their disease. Both of them told them about that.
Thank you.
So, thank you. Is there any other question? No, I haven't seen anyone in the chat. So, let me thank again. Let me thank again Bettina for his wonderful presentation and all these interesting thoughts. And I mean, we're really looking forward to have your book in English. So, and hopefully to have you in presence in Italy soon to present the English version of the book. So I will thank you also all the people that were present for this meeting. And I will remember that on November the 22nd, we will have our third seminar with Thomas Dixon. We're going to talk again about the history of emotion, and the title of the presentation is From Patience to Emoji: Words, Images, and Ideas in the History of Emotions. So thank you again, have a nice evening, and see you soon. Bye.
Thank you all for your questions.
Thank you, Bettina.
Thank you.